Hello everyone, a very warm welcome to all and good evening. I'm Bhavish Bailam, your today's host. So before starting with the webinar, I would like to make some housekeeping notes. If you have joined us from Facebook and YouTube Live, please drop the questions in comment section. We'll answer each and every question at the end of the session. I would like to give brief intro about today's speaker, Professor Dr. Somani. uh, he have received DDS from uh, Federal University of Rio Grande do Norte, Brazil, and have done residency and PhD in oral maxillofacial surgery from UNESP, Brazil, and director of post-graduation program in oral maxillofacial surgery at FACOP University, Brazil, and Director of Post-Graduation Program in Implant Dentistry at UINN GAICEO, Brazil, and is doing private practice in oral maxillofacial surgery and implant dentistry at Sorbani Institute, Brazil. So welcome, Dr. Sorbani. The stage is all yours.
Okay, thank you very much. Are you listening okay?
Yeah, it's clear.
It's clear, okay. I will begin to share my presentation, okay?
Yeah, sure.
Yes. You are seeing my presentation now?
Yes, it's visible.
So, I want to begin, first of all, saying that it's a great honor to me to be here. And I would like to thank to DentistChannel.Online, Dr. Bavish, to permit me to share my work on this topic specifically. That is something that I like so much to do and to speak. This topic is graftless implants in atrophic maxilla. I am doing this approach to treat edentulous maxillar and mandible for, I think, 10 to 15 years with great success. And this is because I like to share this knowledge to everyone. So I really hope you enjoy this presentation. I'd like to introduce myself a little bit. I live in the city of Fortaleza, that is located in the northeast of Brazil. It's a big city. I think the population is almost 5 million of people. We are a little bit far from India, but the internet makes us closer. This is good. And now I can share my knowledge with you as we are really close one each other. So this city, as I told you, is located in northeast Brazil. Fortaleza is a beautiful city. It's very known in Brazil and abroad because of its beaches and the landscapes that we have. And I hope that sometime you can visit us here to know this beauty and to visit me, and who knows, to make some surgeries together. It will be a pleasure to me to receive you here. As Dr. Bavish told before, I received my DDS and my master degree from the Universidade Federal do Rio Grande do Norte. It's a major university here in Brazil. So I received my DDS and my master degree, and after I went to São Paulo, where I received my training in oral and maxillofacial surgery at State University of São Paulo. and I received my PhD in the same university. And later, I have the opportunity to spend some time in Geneva, in the maxillofacial unit of the University Hospital of Geneva in Switzerland. So this is how I was trained in oral maxillofacial surgery and also in dental implants. So after I was a professor at the graduate level in the School of Dentistry of the Unicatólica, which is a Catholic university here near Fortaleza. So I was professor of head and neck anatomy and surgery at Unicatólica, and now I am in private practice at my own institute that is called Institute Dr. Sormani Queiroz Institute, and ICO, which is a post-graduation school here in Fortaleza, where I'm the director of the implant dentistry program and the oral surgery program. And I also have this project with Dr. Cassius Farina from São Paulo, which is a course, an immersion course on zygomatic implants. We call it Zygoma Experience. We have been receiving a lot of doctors, of dentists of all world here, and they have training, 5 days training in zygomatic implants. We have laboratorial training and live surgeries in patients. So it's a very interesting course and a very interesting immersion experience on the universe of zygomatic implants. So I want to begin to speak specifically about the treatment of extremely atrophic jaws with dental implants. And the first question is how to treat these cases of extremely atrophic maxillary mandible. Traditionally, we have 2 ways to treat these cases. One way is using bone grafts. Bone grafts that can be autogenous bone grafts or bone substitutes like bovine bone and other kind of grafts. And we can use a graftless approach. I have been using this grafting approach for many years because my background is as a maxillofacial surgeon. The school where I made my training, they always made major reconstruction in such cases, in these cases of extremely atrophic maxillas. So I used to do this kind of approach for many years. But after I had the opportunity to know some of the great names of the graftless approach, of the all-on-4 approach, and then I migrated from this philosophy to this philosophy. So, and I saw by myself how the results were improved with less morbidity to the patient and simplifying the treatment to the patient. So nowadays, I mostly made graftless approach. It's extremely rare to me nowadays to use this approach with grafts. So why I changed my mind, why I changed my way to perform these cases? It's because when I use bone grafts, I have greater surgical morbidity because I have 2 surgical sites. And in some cases, or in most of cases, I have to have an extra-duodenal area. So I use iliac crest or the cranial vault as a donor sites. So this gives me more surgical morbidity, and the patient will suffer more in the post-operative period. Furthermore, we will have longer treatment time. When you use this bone graft approach, the treatment time will be up to 2 years to finish, since the moment of the first surgery to make the bone graft until the moment of the installation of the process, of the final processes. So this treatment will be much longer. When we compare with the graftless approach, where most of cases, my patient, we will leave my office with a provisional on the same day of the surgery. So it's much less longer time than when you use the bone graft approach. So another problem, mainly when you use the iliac bone crest as a donor site, we have unpredictable graft resorption rate. So I had cases in where I put a lot of bone, a lot of iliac crest bone to reconstruct a maxilla, but in the end, more than 50% of the graft was resorbed. So this is a problem when you use the autogenous bone, and in such cases, can be difficult to place the implant in the end of the healing period of the graft. So this is another reason why I left this treatment and began to use the graftless approach. And other possible complications as infection, graft exposure. This was very frequent when you use a bone graft. So because of this, we changed to the graftless approach. And this case is one of the is one example of how the things can be bad when you use a graft, a bone graft. So this case, it was not it was not me that made the first graft. It was referred to me by a colleague here in Fortaleza, who made this graft 12 months before. And so when the patient came back to place the implants after the healing period, the healing phase of the graft, 12 months later, there was no bone to put the implant. There was no bone to place the implants in the maxilla. So this colleague, this doctor, referred this patient to me. This patient waited 12 months after a major surgery of bone graft. And after this time of healing, there was no bone to place the implant. So we planned to place 2 zygomatic implants and 2 regular anterior implants. And this is what we made. Here we can see the 2 zygomatic implants. And here in the anterior maxilla, we have 2 regular implants. And 3 hours later, after finish the surgery, the patient was using a fixed provisional. So she waited 12 months for the implants, for the graft to heal, and could not place the implants. And now, only 3 to 4 hours after the beginning of the surgery, she is smiling and using a provisional fixed on the 4 implants that we placed. This is the difference between the 2 approaches. It's timeless. It is with less morbidity to the patient. This is why we are using this approach for more than 10 years in our patients. So When we choose to treat the dental jaws with implants using the graftless approach, we can use short implants in the mandible if we don't have sufficient height from the ridge to the inferior alveolar nerve. We can use short implants or extra short implants like the Straumann's 4 millimeters height implants. We can use tilted implants, or you can use bone anchorage techniques. This is what we're gonna see today. The bone anchorage techniques, we have different techniques to use the native bone of the patient to make the anchorage of our implants without grafting. We have the transsinus implants that we use with longer implants that will from that goes from the ridge through the nasal floor. So they will be anchored in the cortical and nasal cortical. This is an option. Or you can use, like this case, 4 zygoma implants and 2 pterygoid implants. And we have the transnasal implants. So I have a lot of possibilities today with different approaches to achieve primary stability for these implants and to give us a good bone to anchorage of these implants. And what permits us to use these techniques is the knowledge that we have areas of force dissipation, of masticatory force dissipation in the maxilla that will form the buttresses, these pillars of the maxilla, where the bone has a greater density than in other areas. This permits us to achieve a good primary stability when we place implants specifically in these areas. And this is what is the basis of bone anchorage techniques. So when you use these areas, these pillars, the nasomaxillary pillar, the zygomatic pillar or buttress, and the pterygoid pillar or buttress, we will achieve, we will have implants anchored in high density bone areas, mainly in type 2 to 3 bone. And with this, we will achieve high primary stability, which permit us to have immediate loading of these implants. So this is the basis of this treatment. This is why we can, most of the cases, place the implants, and in the same day or just a few days after, we will place a fixed provisional to the patient. This is really a great advantage of this approach, this graftless approach. And we almost always, I can say that in more than 95% of the cases, we can achieve a great amount of stability, of primary stability to the implants, which permit us to place immediate provisional on the same day of the surgical procedure. So to use this graftless approach, we have to know some basic concepts of that that is called the all-on-4 concept. Most of cases, we use 4 implants in maxilla or in mandible to fix an immediate loaded provisional. So we have to know some basic principles or fundamentals to use this approach. This is what we call the AON4 concept fundamentals. The AON4 is always, as the name says, we will place 4 implants or in maxilla or in mandible. The region where you place these implants is in the premaxilla, between the bicuspids and incisive area, or in anterior mandible, in the interforaminal region between the mental foramens. And the distal implants, they are tilted to avoid such anatomical important structures and to give a more posterior position of the prosthetic platform. So this way we can give biomechanical stability to make provisional and to give long-term stability for these implants and the prosthetic restoration. Historically, the AON4 concept is being evolution, and so we can see that the first to report the use of this AON4 concept, it was P.I. Bernmark. The group of Bernmark, in very beginning of the use of dental implants, reported the use of 4 to 6 implants in the anterior region of the maxilla or mandible. And the success rates in 10 years was more than 80% for maxilla and more than 90% for mandible. But what we have here, it was that even with such number of implants, like we can see here, 6 implants that we are seeing here, still we had an extensive cantilever. And this extensive cantilever, that was what gave to the system, from the biomechanical point of view, instability. So if you have a great number of implants, but you still have this extensive cantilever, these implants will suffer from the masticatory forces, and it will be a failure of these anterior implants. So the secret is less implants, but with the distal ones tilted for posterior, and with this tilting of these implants, we will lower the cantilever, giving more stability to the system. So this is what permit to us a more predictable treatment outcome. Some authors in 1999, like Matson and colleagues, were the first to report implants placed in AON4 in style. So we can see that this is not a new concept. In 1999, there was authors that were still studying the system, and they placed 4 to 6 implants in maxilla with the distal one tilted. So they used the palatal approach. This is another important concept in the graftless approach to the maxillas that I will talk a little bit more later. So they used the palatal approach, where they had 3 to 5 threads of the implants exposed on the palatal side, and in 86 implants that they placed in the maxilla, only 1 was lost at 3 to 5 point year follow-up, with 100% of prosthetic stability. So this is not a new concept. we can see here, this is figures from the Madison paper in 1999, and they are showing how they tilted the posterior implants to avoid the maxillary sinus. You can look that the distal ones were tangential to the anterior wall of the maxillary sinus. And so they tilted these implants to place the prosthetic platform of the implant more posterior. So this way they could lower the cantilever and give more stability from the biomechanical point of view. And here, this figure shows the palatal approach to the anterior region of the maxilla. And one can see that when you use the palatal approach, we can use longer implants in the anterior region of the maxilla. So instead of using short implants, we can use longer implants in this area, achieving more stability when using this kind of implants. So this is a figure from the Madison's paper, and in which they are highlighting here the posterior implants tilted, avoiding the anterior wall of the maxillary sinus and making the cantilever lower in both sides. So this is very important when using a graftless approach. This other work from Kreckmanov in 2000 demonstrated that it was possible to use tilted implants for rehabilitation with implant-supported prostheses in the maxilla and mandible. So they used 47 consecutive patients. In 25 patients, they used 36 mandibular implants. In 22 patients, they placed 30 maxillary implants. These implants were followed up for 40 months in mandible and 53 months in maxilla. And the angulation of the implants in the mandible was from 25 to 35 degrees, and the maxillary implants 30 to 35 degrees. So we can see here that these figures are from the Kreckmanov and colleagues paper. So we can see here the tilted implants, and when they compare with the straight implants, we can see that when we place the implant tilted, we can be tangential to the anterior wall of the maxillary sinus, and the prosthetic platform will be more posterior. So we can lower the cantilever in 9.3 millimeters, and in mandible when it tilt the implant. So we can avoid the mental nerve, and we still place the prosthetic platform of the implant, the head of the implant, more posterior, and we can lower the cantilever in minus 6.5 millimeters. So we have a cantilever reduction that is good to stability of the prosthesis on long term. And in this paper, the follow-up to more than 5 years, and they showed that no failed implants in the case of tilted implants, and it was the same to the non-tilted implants. So they showed that it's possible to make implants tilted as far as 35 degrees in the mandible, and this was not a problem to the stability of the prosthesis. The same in the maxilla. In the maxilla, they lost one implant only in the follow-up of 3 to 5 years, 2 to 4 years. And they lose even more implants in the straightened implants. So this shows that it's possible not only in the mandible, where the bone density is better to achieve primary stabilization, but even the maxilla, they could achieve a good degree of success in the implants when they make they follow up. So this first studies show that tilted implants could be used, reducing the extension of the cantilever and achieving a good stability from the prosthetic and surgical point of view. So after Paulo Malo, which is a dentist from Portugal, proposed or established the design of All-on-4 treatment with immediate loading concept. So we can say that Paulo Malo is the father of the All-on-4 treatment. So he used 4 implants in the interforaminal region with the 2 distal ones inclined posterior. So he tilted the posterior implants as far as possible, and he made a temporary acrylic prosthesis that was placed up to 2 hours after the end of the surgery. And it was replaced by definitive one 5 to 6 months later. So this is the basis of the whole All-on-4 concept. Paulo Malo established that of what is made until today. This is basically what we make today. And this was in 2003. So 4 implants in the mandible, in the region between the mental foramens, and the distal ones tilted for posterior, and the immediate loading with a provisional made on the same day or few days after the placement of the implants. So this is some pictures of the Malo's paper, where you can see the use of this All-on-4 guide that was proposed by Malo. This is an interesting tool. You use it a lot in our cases. We can place it in the midline, and you use these marks as reference to place the implants, and even to make the inclination of the implants, of the distal implants. So using this guide, it's possible to place the implants. Here, immediate after the placement of the implants, the macro abutments placed over the implants. The distal micro abutments are angulated. Most of the cases we use 30 degrees to 45 degrees angulated abutments, and we can see the where the acrylic provisional were placed over these abutments. An immediate X-ray showing the distal implants tilted to posterior, and the patient with the provisional in place. And after 6 months, the definitive prostheses were performed to the patient. So this is how this treatment how we made this treatment until today. So this we can see in the paper, in Malot's paper, from loading to 6 months follow-up, they have 4 failures of 120 implants. And after, until the 3 years follow-up, they didn't have any other failure. So the survival, the cumulative survival rate after 3 years was 96.7%. So this is really a great result when using this approach. And after the success of the R14 immediate loading on the mandible, Malot used the same concept to the maxilla. So he placed the 4 implants in the maxilla, 2 between the canines and 2 distally tilted in the premolar region. And he placed 128 implants in 32 patients with immediate loading and immediate installation of a temporary resin prosthesis, and evaluated it from 6 to 12 months. And this is how he made this treatment. So the maxilla exposed. Here, he was using a technique to place the posterior implant. Later on this webinar, I will show you this technique, but he was beginning to place the posterior implant that is tilted and is tangential to the most anterior portion of the maxillary sinus wall. Here, the placement of the implant using the R14 guide. Here, the placement of the angulated abutment to correct the inclination of the implant, and the placement of the 2 anterior straight implants. So here is the 4 implants with the abutments in position and the immediate posterior X-ray showing the implants and the patient using the provisional, the resin provisional immediately after the placement of the implants. So this was something that Paulo Malot proposed in 2005, and we are using today the same or very similar protocol. And in his study, in this study, they found after 6 months, from loading to 6 months, 2 implants failed, and with 1 year follow-up, just 1 more failed, with a cumulative success rate of 97.6%. So a very good outcome using this approach. We have different design variations when you use the R14 approach. What will determine which kind of design we will use is the presence or absence of bone in specific areas of the maxilla. This was proposed by Bedrosian in 2008 when he classified the bone the presence of bone in the maxilla in 3 main zones. The zone 1, it was delimited by the premaxilla, the region between the canines. So this region is called the zone 1. The zone 2 is the region between the bicuspids, the premolars in the maxilla. And the zone 3 is the region of molars. So based upon this classification, we can have different variations on the design of the A14. We have the A14 standard, or standard A14, where when we have enough bone in zones 1 and 2, if the bone is available in the zones 1 and 2, we can use the standard A14, that is two tilted posterior implants in zone 2 and 2 straight implants in zone 1. This is the standard A14. So this is an X-ray showing exactly this design of implants. This is something that we do a lot in our patients. So we have 2 posterior implants respecting the anterior wall of the maxillary sinus, and 2 posterior tilted implants and 2 anterior straight implants, and they are splinted with a metallic bar that will support the hybrid prostheses. When we have enough bone in the zone 1, which is between the canine area, if we have sufficient bone in this area, but we don't have bone in the zone 2 and zone 3, we can use the hybrid A14. This variation is characterized by the placement of 2 zygoma implants in the zone 2 and 2 regular implants in the zone 1. These implants can be straight or can be tilted. It depends of the bone situation, but this is what we call hybrid A14. So this is an X-ray showing this approach in one of our patients. So we had a good availability of bone in the region 1 between canines, but we didn't have bone, sufficient bone to place the implant in the zone 2 and in zone 3. So we choose to place 2 zygomatic implants and 2 regular implants. So we have the hybrid A14. And when we don't have enough bone in zones 1, 2, or 3, in none of these areas, so we can use the zygoma quad A14. So we're gonna place 4 zygomatic implants, 2 anteriors in zone 1 and 2 zygomatic implants in zone 2, and we have this A14 zygoma quad. So this is very important, very interesting to note that we have different solutions for this problem, but all of them will result in an A14 design treatment. Okay, so if we see the patient inside the mouth, we're gonna see 4 implants. No matter if it's 4 zygomatic or 2 zygoma with 2 regulars or 4 regular implants, it's always an A14. So to make the prostheses over these implants are always the same way. It don't matter if it's zygomatic or regular implants. The prosthetic management is always the same. So this makes this treatment more simpler than when you use a conventional approach. When you use grafts and a lots of implants, it's easier to work when you have 4 implants placed in correct positions, and we will perform a fixed hybrid prosthesis over these implants. This is why I like this graftless approach so much. So this is an X-ray that shows this Zygomatic approach when we placed 4 zygomatic implants in a patient that literally had no maxilla. She had no bone. We can see here. Here is the maxillary sinus. Here is the nose. And we can see that this patient had no bone. There's almost no bone. So we could use this approach, and this patient had a fixed prosthesis placed in less than 1 week. Otherwise, how could we treat this patient? Probably if we didn't use this approach, we had to make multiple surgical procedures with grafts and with a greater length of time spent to this patient. Other variations that we have, this is what we call the V4. This was proposed by Jensen. When we can use this approach to the mandible, for example, when you have an extremely atrophic mandible and we want to place longer implants on this mandible, we can use these tilted implants on this V4 fashion that will work very good to achieve a good bone anchoring to place the prosthesis. In maxilla, we can use the M4 approach. This is beautifully proposed by Jensen in a very nice paper in which he showed these variations in the design of the AON4. And here we see the AON4 M4 because the implants are tilted in direction of the canine buttress to achieve more stability, more primary stability with this bone that is a bone that has great density, and we can achieve better primary stability to place these implants and make the immediate load in cases of AON4. So these are different designs to the AON4 that you can use in such different situations, transinusal, with grafts or no grafts. So I'd like to talk about biomechanical aspects of the AON4 concept. I think this is another important issue that we have to speak to understand this philosophy of treatment. So when you use the AON4 design, we have some biomechanical advantage that was we had this on this paper from Chen and colleagues on dental clinics in 2015. So what we have that in the AON4 design, the implants follow a dense bone structure, following that bone buttress that I told you before. When we tilt the implants, we can place longer implants. So this is another advantage when you use the AON4 design. Furthermore, tilting implants improves the AP spread of the implant, so we can lower the cantilever with more stability to the system, both to the prostheses and to the implants. These AP spreads enhances the load distribution for prostheses. This shortens the cantilever. So the cantilever will be a maximum of 7 millimeters for maxilla. And this formula of the AP spread for mandible that I'll show you later. So this reduces the prosthetic fracture or instability and marginal bone height stability. The marginal bone height of implants is maintained with rigid prostheses. So when we splint the prostheses with a metallic bar, we give more stability to the implants. So this will protect the implants for the marginal bone loss that can be present. And the tilted implants have similar success rate as traditional implants when splinted together. So this is another important feature of the A14 design. So this is what we can see here. This is another patient that we treated. So we can see here that this implant is 21 millimeters long. This implant is from the ridge through the cortical of nasal floor. So this give to this implant a great amount of stability. So we can see the other implants that we placed, but this one specifically, we had to use this great implant because we placed a shorter implant in this area, but the primary stability was not good to achieve the immediate load. So we changed this shorter implant for a longer implant, and we could achieve good primary stability when we reach the nasal floor. So longer implants can permit us to achieve more primary stability to immediate load. So we can see here that this implant was exactly in the cortical of nasal floor. This picture shows us that tilting posterior implants, we can achieve a greater AP distribution of the implants. So the spread of these implants is of the implants heads and the prosthetic platform of the implants will assure to us better primary stability and better distribution of forces through the prosthesis, protecting the implants to lose bone. So this is what we see on this diagram, on this picture, where we see the straight implant and the tilted implant, and we see how we can lower or shorten the cantilever when we tilt the implant. So this is better to the system. When you talk about the optimal position of the implants, when we are using the A14 concept, we can see here that the anterior implants, the optimal position for these anterior implants are between the canine area. So if I place the implant between the canine incisive area from both sides is the ideal position for these implants. And the posterior implants are optimal located at the premolar positions. these are the best of, or the optimal positions to the heads of these implants in the anterior and posterior area. This spread permits shortening cantilever and better stability for the system as a whole. So this is what we see. Look, if you have a prosthesis like this, we will have great stability, even using 4 implants in the maxilla. So we have implants, posterior implants tilted that are in almost the first molar area, and the anterior implants that are in the incisive canine area. So this is an ideal situation in terms of force distribution along the prosthesis. There are anatomical issues related to the position in the implants in the mandible. This is what we are seeing here. If we have this more rounded mandible compared with a more squared mandible, we can see that in more round mandibles, we can place the posterior implant more posterior. And when they have this shape of mandible more squared, we cannot place the posterior implant too posterior. So we have these implants almost in line, almost in a straight line. And this makes this system not so stable like this one. So in this case, we can't do a very long cantilever. And in this case, we can make the prosthesis more posterior because we have a better spread of the implants. There are a formula that we use that is that the cantilever extension is 1 to 2.5 times the distance from the distal of the most posterior implant, this line that we can see here, to the lingual of the anterior implants, this line that you can see here. So this distance is, we can make the cantilever 1 to 2.5 from this distance. As we can see here, if the implants are two in a line, in a straight line, the cantilever will be shorter than if we have more distributed implant in AP position. So this is what this is an ideal situation. The posterior implant as posterior as you can place, so we will not have a greater cantilever here. And about the number of implants, many of people argue me about using 4 implants. Why not 6 implants? Why not 8 implants? So the question is, more is better. So here we have a great number of implants. And this is not a good situation. This is not stable from the biomechanical point of view. We have implants that are fractured here. We have one implant that is inside the sinus here. And this is a situation that I see more than one time in my career. So this is to show that more implants not necessarily means that is better from the biomechanical point of view. So less is more unless it's kindness, sleep, or toilet paper. And if we see this two situations. I ask you, what do you think, which is the best to clean? What is easier to clean? You think it's easier to clean this situation or this situation? I think that is obvious that this situation is better to clean than this situation. This is why I never would make such a great number of implants to fix a denture on the patient. I think that this is always the best way to treat. And the result from the aesthetic and phonetic and functional point of view is the same or even better with this approach than with this approach. Sometimes we choose to place more implants, but this is an exception. As in this case, this patient, I had to place more implants because I begin planning to place 4 implants for a conventional, a standard A14. But I didn't achieve a good primary stability in some of these implants. So during the procedure, I have to place 2 zygomatic implants. And I even placed a pterygoid implant here to assure that this patient could use a prosthesis with immediate load after the surgery. But in fact, this was an exception. Normally, I would not make this kind of treatment. This was something that I had to do because of this situation, which I didn't achieved a good primary stabilization in 2 of these implants. So I placed the zygomatic implants and the pterygoid implant. The palatal approach is another cornerstone of using the A14 treatment. In the palatal approach, we place the implants more palatal to the ridge, so some of the threads of the implant will be exposed. This is something that people always ask me about, if this will not harm the treatment, these exposed threads. But I can assure you that this is not a problem, because we have the palatal fibromucosa, which is primarily keratinized tissue that will protect the implants from having problems and from the bone resorption. So this is not a problem. We can let these threads of the implants exposed without any problem. So we use this technique a lot to give implants, longer implants, and to achieve more primary stability. So this is one of the things that is routinely made when we use the A14 approach and the graftless approach. This is well established in many papers in the literature. We have these papers from Madison and this paper from Miguel Peña Rocha. It's here, that shows the use of palatal approach in cases of jaw atrophy, and they made this study with 69 patients with atrophic jaws, 490 implants for 69 prostheses, and from this 330 implants with palatal approach. So they found 97.8% of success after 2 years of load, with only 0.67 millimeters of bone loss. So they showed this these well-illustrated cases with up to 5 years of follow-up and good stability of the tissues with very, very low rates of bone loss. So it is possible to use this approach, this palatal approach, and you use it a lot. Now I'll show you a sequence of treatment, how we do this graftless approach, this all-on-4 approach. So everything begins with a good clinical evaluation, and it's very, very important to evaluate the smile line and the prosthetic space of this patient. So we ask the patient to smile, and so we analyze how the patient shows the teeth and the gingival area, to know if it's possible, if the patient has sufficient prosthetic space. For example, this patient has a very low smile line, so this is good when we are doing hybrid prosthesis. So this is show us that it will not necessary to reduce too much bone in this case specifically, but there are other patients. This patient also has a very low smile line, but when you see patients like this that is showing the gingiva when smiling, this show us that it will be necessary a great amount of bone reduction to this area to achieve a good aesthetical result to this patient. The same for this one that is showing the teeth and part of the gingiva when smiling. So these patients with a high smile line deserve a very caution when we are planning the osteotomy, as I will show you now. So what I do is I ask the patient to smile. I will mark the smile line with some kind of marker. Here I use a Detland Bull. So this is the smile line of the patient, and I want that the prosthesis, the transition of the prosthesis with the gingiva of the patient, it will be as high as possible, at least 5 to 8 millimeters above the smile line of the patient. So I mark the position then that I want to place this transition between the prosthesis and the gingiva of the patient. And after the patient is anesthetized here, I will make some marks through the gingiva and the bone with a round burr, as you see here. So these are the marks. And when I expose after I made the incisions and expose the bone, I will make the horizontal osteotomy according to that marks that I placed before. So this is a technique to mark where to cut the bone according to have a good static outcome here. So this is what we achieved. We removed the teeth after, and the root teeth, and we placed the implants in an adequate height to avoid aesthetic problems with the prosthesis. And here is the patient making this is the the wax test. The teeth are mounted in wax. So the patient is asked to smile, and we can see that the amount of bone that was removed is what it was correct. So the patient will not show the transition between the prosthesis and the gingiva here, like we show here. In this patient this is a patient from the internet. It's not my patient, but it's just to serve as an example. But we can see that in this case, it was there was no good diagnosis on the position of the lip related to the gingival. And what we see here is that when the patient smiles, she shows the transition between the prosthesis and the gingiva. So this is a catastrophic result that we have because of a bad diagnosis. So we cannot do this. We have to make a good assessment of the gingiva, the lip to teeth relationship. And if the patient has a low or a high smile line, to avoid this kind of problem. So talking about the technique, we most of the cases we made these surgeries. If it's a case of standard R14, we will make these cases in office setting. But when we are doing the major cases of zygomatic implants, we do it in the hospital setting, in the operative room, mainly with local anesthesia and IV sedation, but in some cases, zygoma quad or some cases of hybrids R14, we made under general anesthesia with the patient intubated. We use these anesthetics. We mix ropivacaine, which is a long acting anesthetic, local anesthetic, with chilestezine. So we mix these two solutions one by one, and we will do the anesthesia. We begin with the zygomatic facial nerve extraorally. After we made the anesthesia of the infraorbital nerve, we make the infiltration in the vestibular area, anterior vestibular area. We make the block of the posterior superior alveolar nerve. We make some infiltration of the anesthetic in the vestibule, in the premolar and molar area, and you make the palatal anesthesia, incisive and great palatine nerve. So this is how we make our infiltrative anesthesia when we are doing this with local and IV sedation. So after we make the incision, and the incision is towards the palatal side of the maxilla. And so we do the mucoperiosteal raising. We raise this flap, and depending, in this case, we were making the zygomatic implant, so the exposure is wider. But when we're gonna do the standard R14, we don't go so high in detachment. But after exposing all the area that we're gonna use to make the surgery, we make this palatal suture to maintain the palatal flap retracted. And after that, we're gonna do the osteotomy. The osteotomy is made with burrs. in low speed. So we're gonna cut the ridge as planned before with the smile line analysis that I showed before. So the objective of the osteotomy is to create prosthetic space, an adequate prosthetic space, to hide the prosthesis gingiva transition, to flattening the edge. So we have with this flat denture base, and to level the curve of speed. So we have the edge totally flattened, which is better to the confection of the prosthesis. So we made this osteotomy. So here is an example. This is a partial dentate patient that we placed by maxillary R14. So after exposure of the crest, before the teeth extraction, after the extraction of the teeth, so we see that the ridge is very irregular. So we have to flatten this ridge. This is better for the prosthesis. This is better to the placement of the implants. So we use the burr to flatten the ridge, to regularize the ridge. And after that, we placed the implants. So we see here the palatal approach. And in this case, we had to put, besides the four anterior implants, we placed 2 pterygoid implants in the posterior area. So we see that the ridge is very, it's easier to work with this flattened ridge than when you have an irregular ridge like that. So this is why we made this bone regularization. So here in the mandible, so when we extract the teeth, look like the ridge is irregular. It's difficult to work. It's difficult to the prosthesis. So after we expose the bone and we do the osteotomy, the osteotomy, and here making the fracture of the ridge after we begin the osteotomy with the burrs. So we fracture the ridge and remove the bone. And after this initial remotion of the bone, we gonna regularize this bone with the burrs, and we have a flattened ridge, which is better to the placement of the implants, as we see here. After that, we make some Anchorage sutures here, and the finish of the procedure. So we, in cases of zygomatic implants, we are seeing here the drilling process. So when you use zygomatic implants, we use longer burrs, longer drills. So for example, here we are using a drill that is marked until 60 millimeters. So normally you use implants that are regular implants are 11 to 13 millimeters, and the zygomatic implants we use from 30 to 60 millimeters. So it's a big difference in the height in the height of the implants. Here, placing the final positioning of the zygomatic implants, you can see that the implant tip is entering the zygomatic bone here, and here is the head of the implant at the level of the ridge. So we are positioning the head of the implant, and here showing the torque emitter showing the primary stabilization that we achieve with these implants. After we suture, after we finish the procedure, we're gonna fix the provisional over the implant. So this is, we are fixing this provisional with resin over the head of the implants. And here, immediately placed provisional over the 4 implants. So we can see here the basis of the prosthesis of the provisional and the provisional in the patient's mouth. So this was placed only few hours after we placed the implants. So this is the post-op X-ray control, and this is what we want to achieve at the end of the procedure: a perfectly polished prosthesis with this flattened basis that is fixed to the 4 implants that we placed. When we don't have a perfectly polished prosthesis like this, we have inflammation, we have accumulation of food under the prosthesis, how you can see here. This is not patient's guilt. This is a problem with the prosthesis that was not made following the correct principles. So we can see that this prosthesis was not perfectly polished and facilitate the accumulus of food and other things from the oral cavity. So this will result in inflammation of the gingiva. And this is to show you, I will finish my presentation showing you how this graftless approach can help the patients to achieve their goals with a less invasive procedure. So this patient was a young man that had an assault and was shot in the face by someone. So this shot basically distracted the entire maxilla of this patient. So we can see here the metallic shells of the bullet that destroyed the maxilla of this patient. This patient has 33 years at the time he was shot, right in the face. So he lost almost half of his maxilla. And many surgeons refused to treat him because it was a very difficult case. This is a very difficult case to treat with graft, because we have such amount of destruction. We have too much fibrosis. We have too much scarring. The tissue is not good to cover a graft. So it was difficult to graft in this area. So this patient has no hopes, and he went to us almost crying, asking for a treatment. So we proposed to him to place zygomatic implants and conventional implants in where it was possible to place the implants without grafting of this area. So when we exposed the maxilla of the patient, we could see this communication with the maxillary sinus. We could see these shells of the shot that the patient suffered. And we could see this great amount of scar and fibrosis of the area. So we can see here the firearm shell fragments that we found during the surgery. And it was possible, unfortunately, we have a technical problem here, but it was possible to place 2 zygomatic implants and 2 conventional implants. And the patient was happy with his prosthesis. So let me open another one here. There was a problem. I want to show you the final result, but it's possible to see here on the small ones that we could place the 2 zygomatic implants and 2 conventional implants, and then the case with the patient happy for giving a prosthesis fixed to this implant immediately. So this is what we can do for the patient with this graftless approach. And this is what I wanted to show you. I really want to thank to DentistChannel.Online, Dr. Barish, and all of you that are here attending to this lecture. And I hope that you were able to understand how this philosophy of graftless and iron-4 can give to us, to our patients, a great way to treat the edentalism and the extremely atrophic maxilla and mandible. Thank you very much.
Yeah, it was a really great session. So before that, I would like to share my PowerPoint presentation where can you stop sharing, sir?
Well, Dr. Barish.
Yes. So Dentist Channel Online, it is the first digital media platform which create academy commercial for dental student organization which dental industry leaders and offers the several services.
Just to answer this question, which one is better in case of atrophic maxilla, patient-specific implants or iron-4 zygomatic implant? I think my first option is iron-4 with the zygomatic implant, but if it's not possible, or if it's a failure, the patient specific or customized superior implant it's a good choice for this case. But my first option is always the zygomatic implants. Okay. Thank you very much. I'm sorry that I think I spent more time than I should, but this is a very interesting topic, and I always like to speak a lot about it. So I'm sorry, Dr. Barish.
Yeah, I would like to continue. Uh, so for so Dentist Channel Online provides dental news, webinars, courses, events, Prime videos. This is all for the Prime membership, and there are buy and sale option, then contribution to the videos. You can share your videos to the platform, then dental businesses, and submit articles also. And if you want the organization to help with host events and then uh, develop a website for you, then participate in certificate event registration, the all things will be provided by the Dentist Channel Online. There are more than 705 dental webinars are on the website. 25 plus dental workshop have done. There are 300 plus oral care videos under the Save Tooth program, and there are 400 plus national and international speakers are available on the platform. Then there are 40,000 plus participant certificate issued. We have pride to sharing that Dentist Channel Online entered into India's book record, have maximum speaker participated in a virtual conference of oral implantology. The Prime membership benefits will be personalized account with Dentist Channel Online. You'll be access to all the webinars and workshops, special discount and on the dental courses, and will provide a certificate which is carrying one valid CPD or CDE point where you can download from your website, and then regular updates and dental news. uh, then we have some articles and participate as a speaker. You can be as a speaker also and publish awareness video on the website. This is the sample certificate which will be allotted to a participant who are a Prime member only, which will carry one CPD point. So the annual Prime membership will cost you $7.99 per year. That is $10 in USD. If you use my promo code, that is BB100, you'll be getting a discount definitely. The upcoming webinars are palate, uh, platelet concentration in dental practice, gel to make it well, and aesthetic, facial aesthetic, and permanent makeup. Now, this is the Dentist Channel Online. We have Facebook account, Twitter, Instagram, LinkedIn, YouTube, then WhatsApp and Telegram. You can definitely go and check it out. This is the Dentist Channel Online, and this is our address and contact details where you can contact us. That's it. So yeah, we have some questions, I guess, as you, yep. Yeah, I guess you have answered that question, right?
Yeah. Yes.
Okay. Okay. So we don't have any question further, I guess. And it was a very informative session, doctor. Personally, I really enjoyed it, and that's it, I guess. Thank
Okay.
you all, and thank you very much for your time, sir.
Thank you for your invitation.
And I'm hoping we will be meeting soon for further webinars.
See you. Bye
Thank
bye.
you. Bye bye, and have a good day.